Patient's missing 2 premolars, class 1, actually slightly class 3. And so we cannot pull forward these molars while having any of the anteriors retract. So we're going to look to use a TAD-based appliance. And so, yeah, we're just finishing closing those spaces, but it's definitely a bit of a slog, but it's going to save her $10,000 in implants. So now you see I turned it, kind of changed the angle. That's where you have the higher risk of potential fracture, but again, very, very unlikely. And now I changed my angle to that 45-degree angle to the long axis of the tooth. And because this is a zygomatic arch TAD, you don't want to have too little of the TAD showing, so you want enough of it sticking out that the tissue's not going to try and grow in over top of this TAD. Well, thank you everybody for joining me. Okay, so patient comes in, right? She comes in and her chief complaint is not crooked teeth, it's gummy smile, right? So she's like, I hate my gummy smile, I show more gums than my teeth. You look at her bite, she's a class 1 occlusion, right and left side, a little bit of crowding on the lower. She might actually have a bit of a Bolton discrepancy. The quick and dirty way of knowing if somebody has a Bolton discrepancy is their upper lateral incisors are the same size as their lower incisors. If they're the same size, she probably has a bit of a Bolton discrepancy. And so that's why she's biting in crossbite and has a tight bite, has to do with those small lateral incisors. So you heard me talk about this before. What are the methods we can use to improve that? Well, either we have to make the teeth slightly bigger with restorative, or we have to do IPR on the lower to make them slightly smaller. Those are kind of the 2 main ways. So you can see this right off the bat just by looking at the laterals and comparing them to the lowers. And you'll often see if they're in a class 1, they're going to be biting in a crossbite or edge to edge in the anterior region. Obviously, we talked to her about the fact that she's kind of biting edge to edge, chipping, damaging her teeth, but she wants to talk about fixing this. Well, you know what the options would have been back in the day is you'd say you need to go ahead and get a maxillary impaction surgery to remove a chunk of your bone because you have maxillary overgrowth. That's your problem. Your maxilla grew too much. Well, that's not really in the cards. And so the other option is to go ahead and place TADs. So what we've done in this case is we've gone ahead and we've placed the TADs in the posterior just like you saw before. Now we know that we can just go ahead and increase the amount that we're doing. Like instead of just doing one side, let's do the other side. And instead of the first case you saw where we just intruded the anterior teeth, why don't we go ahead and we place 2 TADs in the anterior and we intrude the anterior as well. So we're essentially using 6 TADs to intrude the entire maxilla. So in terms of the ClinCheck itself, it's actually remarkably simple. There's very, very little going on with this plan. Here's version 1. I'm not going to go through every step, but we've got a bunch of attachments on. We don't have anything actually showing on the lincule of the teeth. We'll have to change that. But it's just a bunch of attachments. The teeth literally just kind of straighten a bit. The technicians have shown the entire arch intruding. Now, I will tell you something. It does not matter if this shows intrusion or not on the ClinCheck, because the TADs do not care that the ClinCheck shows no intrusion occurring. The TADs only care that they have an elastic that's pulling on them all the time, pulling those teeth into the bone. That is the only thing that actually matters in this case. So don't sweat the fact that the ClinCheck does or does not show intrusion of the entire maxilla. But yes, there is some torque correction going on there. If we go to the Bolton, I thought there was a Bolton, but it actually shows here it's not as significant. It's only 1.06 millimeters, so we aren't actually going to have to do any Bolton correction right now. There's one thing I adjust, really, in this case here, and that is, well, 2 things. I'll show you them both. One is that we are going to be hooking on a button from the lower first premolar to the upper first molar. And the reason why we're doing that is we want to try and keep this patient from going class 3, because as we intrude these maxillary teeth, what's going to happen is her mandible is going to want to come forward because we're creating an open bite everywhere. We're creating it in the anterior and the posterior. So as we intrude, her mandible, because it's a hinge joint, wants to change vertically, but also it's going to change anterior posteriorly. So we're utilizing some elastics here to try and prevent her mandible from coming too far anteriorly and ending up class 3. So just light elastics that she's wearing at nighttime in this area. There's one more thing that we're gonna actually do in this case, which is kind of gnarly, is we're looking to use, this is a Schalk original. I've never seen anybody do it before, but what we're actually doing is we're asking the technicians to place 4 attachments directly on top of each other. On the 1-1 and the 2-1, please place 4 attachments stacked one on top of another. Please see Kyle Lee, this case number for reference, ClinCheck number 10 as an example. I'm not going to be filling these attachments, but we'll be cutting the lingual attachment with a burr so that the elastic can hook on and intrude those teeth. The interesting thing about this case is actually that I do this technique on the first ClinCheck, and then on the second I use slits instead, and she found it so much harder. So I've actually gone back to using, let me go here. I've actually started using this technique again. So essentially, we line up these attachments, we ask for 4 attachments on top of one another, and then what we're gonna do is we're going to cut the trays. Let me show you a picture. So this is just a quick mock-up I did for my staff. So here's the tad on the buckle. We're gonna hook the elastic onto the tad. It's gonna go around. The trays are gonna be in. And then what we've done with the trays here is we've actually taken the burr and we've chopped out a portion of the tray. The reason why we've quadruple stacked this attachment and then we're cutting it with a burr, just like with a surgical burr or a diamond burr, I don't care, of any burr, is we're trying to just leave it so like one attachment worth is still like a full length attachment here. And then everything else is actually, we've removed that portion of the attachment. So then the elastic can hook on really, really easily. It's almost like you've put a little, like a knob on the inside of those teeth so that you can hook the elastic on. No one's ever done this before as far as I know. I think I'm the first to do it. I kind of just thought before, I'm like, oh, these patients are struggling trying to hook their elastics onto like slits that we're making in the trays. And so I was like, well, why don't we just do this? Why don't we quadruple stack an attachment and then cut it? And then we do unfortunately have to cut every tray with a burr, but then they can hook their elastics on. It's going to be way easier. So that's the design. Again, ClinCheck is very straightforward. We place the tads. We got the posterior tads. We've got the anterior tads. This is what it looks like then with our elastics hooking underneath our quadruple stacked attachments. And so we get to the end of our first batch, which is going to be here. Maybe it was actually not there. The tads are placed in April of 2023. This is now June of 2023. Oh, here's what happens. The tads start getting loose in the anterior. So what we've planned to do then is all we're going to do at this point is unthread the tads since they're getting loose, and we're just going to move them into a new location. Right? So you can see from here, between the centrals and laterals, we just move them over. You can see this is like the residual little lines, or like, I don't want to say scarring, it's not going to scar, but you can see where the tads were a few months later as we've moved those tads between the canines and the laterals now instead because they were getting loose. So if the tad has not fallen out entirely, you can just move the tad. You don't need to do a new one. But if the tad comes out of their mouth, you have to place a new tad. You cannot take a tad that has touched an unsterile, gross surface, their finger, the table, the toilet, whatever, and place it back in their mouth. You need a new tad. What's interesting from these photos from the very beginning, going, let's say, here even, look at what does happen is as these teeth intrude, for the most part, the gingiva and the periodontium move with it, but a little bit of the tooth is actually going to be pushed up slightly underneath the gingiva, and you'll see a little bit of like a rolling of the gingiva, like and I don't want to say clumping, but essentially there's like extra gingiva there. So as you can really see it in this image the most, right? How there's a little bit of a crease in the gingiva now compared to where you first started. Right? No, it's all smooth. So the clinical crown has actually gotten slightly shorter. You can see it again too if you really compare here. There's a bit of staining on the teeth from when this patient was younger. The gingiva would have stopped right here, And this staining was there from poor hygiene as a young kid, and the gingiva continues to establish its position. Well, now if you look at where the gingiva is here, you can see that the gingiva is not too far off the staining position. This is partway through treatment, but then as we go further into treatment, the gingiva does kind of relax a little bit, and it's not as significant. So the gingiva does remodel slightly. So you don't need to expect that you're gonna have to use a laser on some of these cases, but you may actually wanna jump in there with a laser and then just do a little bit of a gingivectomy at the end of treatment. Okay, let's go back then. So all we're doing from this point here to this point here is the basic intrusion. Well, now she comes back in and all we're gonna do is get her more trays. So on her plan, it's again, nothing crazy. It's super, super straightforward and easy. All we're doing is just continuing on with another round of aligners. All I've really told the technicians to do is just intrude the anterior, like intrude all of the teeth a little bit. And the same thing will happen on the next treatment plan here. It's pretty much just keep intruding all the teeth a little bit. But again, the elastics are what's doing the work. So this is where she's at after her first batch of aligners. And then this is where she's at after her second batch of aligners. So from here to here. It's crazy. So she had a pre-consult. This was her a year before she didn't start treatment. Actually, this is 3 years before. It's a really cool thing that we often talk about gardening, that you want to grow your garden of malocclusion. So you do a good consult. When she came in 2020, this is February 9th, so right before COVID, we did a stellar consult. This patient actually lives 6 hours outside of Grand Prairie. We did a killer consult. And so because we didn't just do it chairside and throw all this information while she's sitting with the hygienist, instead we brought her back for a proper consult. 3 years later, she shows back up and says, I'm finally ready to do this. The number of times we have that happen per week is crazy. Like I had one show up who was in 2017 and they just came back to start their treatment now, finally, after 8 years almost, they're finally ready to go. And so we saw her that first time, then this is where she is 3 years later, after her first batch and after her second. So we probably intruded her entire maxilla. I would say maybe 3 millimeters, and we're gonna keep going. So we're not done yet. I'll keep going until she's happy at this point. So usually that's how it goes. I'll say if you're happy, like this is obviously very good compared to where we first started. I don't wanna keep them hostage in treatment for forever because now we're at about 1.5 years. So we started, this photo at least is from, she started, the TADs were placed in 2023 in April. So this is just under 1 year. Actually, this is 9 months. Now I will show you something here. This is her next photo. So this is actually a few months later. I did not place the cutouts in the trays for this batch. We just made slits with scissors instead. And she found it so much more uncomfortable that she stopped wearing them. And actually maybe that's why the gingiva looks a bit less rolled, is I think she actually maybe has had a little bit of relapse potentially. And she, in that time frame, she did have a baby. So I'm not gonna push her too hard for not wearing the elastics as well as she could. She's very committed to continuing this process. In terms of relapse, would we expect a little bit of relapse? Yes, you might expect a little bit of relapse. But are we expecting that this is gonna go back to where it was? No, not a chance. Like this is really, really good. So I do not expect that you're gonna see a significant amount of relapse here, as long as you've established a stable occlusion in the anterior. I'm gonna show you how we place the TADs. Placing TADs is not super hard. The method for placing TADs that you're gonna do is to start off with, you can use an endo explorer or even just a regular explorer, and you're gonna make a little indent. So you make a little indent into the gums. And the purpose of making this indent right now is, so we're making this little indent into the gums up here. Now this is gonna be a zygomatic arch implant, which is way harder than anything, like it's not super hard, but it's harder than anything else I'm showing you right now. So we make the indent, and by having that implant, we now have a location for the TAD as it pushes against the bone. That little indent is allowing the TAD not to slip or move on you. So that's the reason you're doing the implant. And I have frozen the patient when I'm placing the TADs. I always place them. Essentially, the apparatus, the assembly here, in most cases, is just a handheld driver. So it's literally like a screwdriver where you just twist with your fingers to actually make this spin and put in the TAD. So for the zygomatic arch ones, the ones that are more apical, we're going to start out going horizontal and then we change our direction. And I don't actually grab enough tissue. This is not the most beautiful TAD placement in the world. I'm not actually really catching it here, so I'm going to go back. And so the idea is that either you're placing these TADs directly in, like you're going 40 or 90 degrees to the long axis of the tooth and just going between the roots. That's an interradicular TAD. Psh, that's it. The other option is that you go at a 45-degree angle to get into the zygoma or to get into the buccal shelf. Again, the interradicular ones are really, really easy. You're literally just landmarking, so you're looking with a mirror and probably check your pan first to see where the roots are, like relatively speaking, and you start twist, 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 twist. If you hit the root, you literally just back it out a little bit, you change your direction slightly, and you keep going. That's literally how easy it is. If you hit a root, you're going to feel it because it's going to kind of like have resistance, or if you're going right beside a tooth and the threads are hitting the root, then again, you're going to feel it as you're turning, you're going to feel the threads actually hitting the root. There's no risk of harm to the tooth if you're using a handheld TAD driver when you're doing TAD placement. There's always a risk, 1 in 10,000, that you're going to break a TAD. I very, very, very rarely have ever heard of it. If you ever did break one, you'd probably raise a little flap and you'd grab with some hemostats and you'd pull it back out. You could also theoretically just leave it. Depends on where the break is. It's not something that I want you to freak out about. But you're not going to really break a TAD using a hand driver. Like, it's just kind of the reality. It's going to be very, very, very uncommon. Because we're placing this TAD into the zygoma, if you're doing that, you want to start off going more horizontally first. And then, once you've kind of established the position and you get a little bit of a grip in the bone, now we're changing the angle. Let me go back. To go at a 45 degree. So again, this is from the start of the placement, and I don't do a beautiful job to start with here. I did not actually feel the TAD kind of catching enough before I changed my angle. So it's not really catching, it's just kind of spinning there. It's not doing anything, it's just spinning in the tissue. And I'm like, oh, it's not grabbing. Okay, change my angle back so it's 90 degrees. And then once it starts to catch, I guess I'm not quite 90 here, but once it starts to catch, then I can change the angle more. So now you see I turned it, kind of changed the angle. That's where you have the higher risk of potential fracture, but again, very, very unlikely. And now I changed my angle to that 45-degree angle to the long axis of the tooth. And because this is a zygomatic arch TAD, you don't want to have too little of the TAD showing, so you want enough of it sticking out that the tissue's not going to try and grow in over top of this TAD. So there's actually a collar, a pretty big collar on this TAD. This is a TAD from Ormco. Ormco Vector TADs is the brand. They come with a driver and a kit and everything else. And so that's the TAD placement. You brush the TAD just like you brush your teeth. It's the exact same process pretty much. Now again, TADs are not magic. Please know that TADs do fall out in 30% of cases. And then you replace it, like what happens? So that TAD comes out, you just replace it in a different site. You change the position of it. Well, you will find that the patients who lose their TADs are more likely to lose more TADs because they have a higher or lower bone density. So I warn all my patients, this might not be successful. So you could, in this case, go ahead and place that TAD into the zygoma like I showed in this image here, which I sometimes do, or you could have placed it right between the roots. Now, why would you place it in one versus the other? Well, placing it between the roots, as the teeth intrude, eventually the tooth, the crown, will start hitting against the TAD, and you've reached the limit of how much you could theoretically intrude. So you don't want to go too low with it. And you can actually even see in this photo here, I place it just literally between the roots of the teeth, which is the easiest to do. But as we progress through treatment from where the TAD was originally placed, to where the tissue gets pulled up to at the end, there's not a lot more intrusion that we could do before the crowns would actually start to hit that tad. The other thing is that between the roots of the teeth is more likely for tads to fail. The failure rate is higher. Just one little fun fact for you is lower anterior is the worst site for tads. Pretty much just straight up don't do it. It's like a 50% success rate. It's terrible. Do not place tads in the lower anterior, period. I mean, obviously you can if you want to, but don't do it. So here's a buccal shelf. So what you didn't see there is that I would have made the indent first, and then I start placing the tad. In this case here, I can kind of come on a direct angle to start with. Turning the driver. The buccal shelf is way more dense, so it does take more effort and energy, but fortunately, the buccal shelf and the zygoma have a better success rate of tads not falling out. So you can see how much I need to turn it, right? I'm actually turning it quite a bit here. So I probably turned it for these really, really dense bone areas, maybe even like 30 times. In total though, I mean, what's the length of this video? We're looking at right now like a minute. There's our tad. Here's another angle on the other side where we're placing 4 tads. See, I didn't actually landmark here, so it's a lot harder. Like the tissue is slippery. It's a free gingiva right now. And free gingiva is not the best tissue. It's better to try and place it into attached gingiva because the free tissue, the free mucosa pulling against the tad is more likely to cause a failure of the tad. Sorry, I'll zoom out. Hopefully you're not getting seasick right now. I'm also going slower just for the video because I really want to make sure we're capturing it. But again, some anesthetic. Pinpoint it with your Explorer. And placement of the tad. I want to show you just Chang has a video showing in the anterior region. He's the guy I learned a lot of this from. So anybody wondering where can I learn more about tads, I'll show his YouTube channel in just a second here, but Chang. So he's just showing it in the anterior. Oh. So makes his pinprick. And then here on the right, you can see it now. Then he landmarks it. Again, anterior mandible, maxilla is okay. And it's actually very easy to place the tads. Like it's super, super easy because it's so clear where the roots of the teeth are gonna be. So you literally just go ahead and place those tads. It's like screwing a drywall screw, and this whole video is 28 seconds, and that showed him doing the pinprick and placing the tad. So this is the channel here, Chang Ortho. Maybe one day I'll finally have 90,000 subscribers, but we did break 1,000, which we're making progress here on all our platforms too. We're really starting to make some traction. So subscribe to our YouTube channel. Screw Chang. You need to get the pun on that since screw, tad, get it. But you can find lots of good stuff on tads from Chang. The other way that you can place them in the palatal here is to use a guide. So I'll show you some palatal stuff in just a bit. I know where it's always like, should we even take a break at this point? But I'll show you the tads in the palate. So when you're dealing with the palate, you have a guide. You can use a guide. You don't need to. You can have a contra angle attachment that just goes on. This one looks way more hardcore, but you can just have a normal like contra angle piece that goes in, and you just ballpark it. Like you just look at where the roots are with your mirror, and you just literally place it between the 2 roots is what I did for this patient we just saw. But this is where you want to place tads in a very specific spot so you can hook an appliance directly onto it in that same appointment. So you just essentially use this guide. It just sits against the occlusion of the teeth. You just turn the tad. Normally you'd look to use an electric tad driver, or just what's even better is an implant motor. You can just use an implant motor, and you're placing the tads then after you go back and forth a million times until you get to the right depth, which usually the guide will stop it for you. Yada, 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 yada. Take that out, and this is what you're left with, is your 2 tads. And then now you can go ahead and fabricate your appliance to go over top of this. and you're in really, really good attached gingiva, these TADs in the anterior palate almost never fail. They are so good. And then I just want to show you a quick example of what TADs in the anterior palate look like, why you would use them. Patient's missing 2 premolars. Super class, or class 1 here, essentially, like she actually slightly class 3. And so we cannot pull forward these molars while having any of the anteriors retract. So we're gonna look to use a TAD-based appliance. Essentially, then we're using the guide. These are the TADs from PSM. We place them with a guide into the anterior palate. So drop a freezing, put the guide on, either use an electric handpiece or a manual one, and then you place those TADs into the palate. On top of those TADs, then the appliance goes over top of them. And there's a little cover screw that's gonna attach the appliance. The appliance is also going to cement to the teeth. So it's cemented to the 6s for those Americans on right now, first molars. Glue to the first molars. That's gonna help drag forward those teeth using this spring. And then the cover screws are what's attaching the TAD to the actual appliance itself. And then this is just something that can be adjusted every week, or every month, I should say, to tighten, to pull the teeth further forward using the spring. So that's essentially the method by which we pull forward these teeth little by little by little. We have the anterior aspect of that appliance, or of the aligners. So we're using aligners in the front, and then in the posterior, we're just literally using this appliance to drag forward those first molars, yada, 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 throw some elastics on, get a full tray again, finish closing the spaces. And you can see this is not fast treatment. Since this is where we're at now after 2.5 years, again, we're moving forward that second molar here with actually an aligner. And so, yeah, we're just finishing closing those spaces, but it's definitely a bit of a slog, but it's gonna save her $10,000 in implants. So that's the method by which you can place those TADs into the anterior palate. The goal is not, I don't want this to be an infomercial. I don't like selling things. I don't think that I do sell Invisalign when I am talking to patients about it. I think that Invisalign makes sense because it's going to improve the patient's bite, their function, their health, and ultimately their life. I think joining Clearly Select is not me right now selling anybody on anything. I think that it's me discussing the goals of what I'm trying to do with my life to help make a difference in a bigger impact. I know that I could see about 400, 500 patients a year, but since 2020 when I started lecturing, I've lectured now to over 3,500 dentists. If you assume that each one of these dentists has 1,000 patients, you're looking at 3.5 million patients potentially impacted from what I've been able to share with doctors. There's 300 million people in the States. That means that every one doctor, if this was just the States, every one patient in 100 has gone to a doctor then that's been a clearly aligned, educated doctor. Like, that's amazing. And so the things that I want to provide to a more in-depth group is, I feel like just providing courses isn't enough because you don't get that continued support. So there's really 5 things we're looking to accomplish. Number 1 is knowledge. You need to have information and education in terms of how to actually do this, right? What you're doing right now, giving up your evening to sit there and listen to me go on, right? And so we have over 180 hours worth of education available in so many different topics, whether you're a brand new provider or whether you're very experienced. We've got the entire library of everything Clearly Aligned related is available to you, and much more that's only available to Select, because that's now kind of my baby, my focus. So that's number 1. Number 2 is I want to give you confidence, right? And give you support with designing and planning cases, just like we're doing right now. Our team designs and creates ClinChecks for you to help push you outside your comfort zone and take on cases that you otherwise wouldn't, but knowing that you have experts that are going to help design it for you and keep you in the guardrails. Even from this alone, the goal would be is that you're taking on 10 cases you otherwise would have referred or not treated. Even at whatever, call it $5,000 per case, that's an extra $50,000 worth of revenue coming into your practice if you're able to do that. So we provide, I would like to say, the most comprehensive ClinCheck reviews in the industry because we like to talk. Number 3, community, right? We've got a world-class group of dentists who focus on orthodontics, but also in other areas. It's amazing seeing the different speakers that are available in pediatric airway and restorative, in other things that support aligners or even are separate from aligners entirely. But I think the quality of what we're trying to accomplish attracts other really quality individuals. And so the quality of the community is very, very high in terms of the goals of what people are trying to accomplish. The next one would be logistics and profitability. So you could have all the knowledge, but not know how to implement it. So we give you access to all of our forms, our scripts, our checklists, the new patient videos that we create, dental monitoring support, everything that you need to be profitable, but also we give significant discounts to doctors. We have to have doctors go through a non-disclosure agreement. You have to sign it. It's just the reality because we cannot share some of these discounts without having an NDA signed. It's just we have specific contracts in place that require that. But I can guarantee you that you will be saving on average $25,000 or more based on lab fees for aligners as well as other products. So there's a significant savings that comes from our purchasing power because the volume that our doctors are doing is significant. And then the last thing is accountability. And I'd like to say this, that we didn't become, I always say we because it's my team, but I guess I didn't become the world's youngest diamond provider as a GP by being a pushover. Like, I'm going to tell it to you straight. I'm going to make you set goals. We're going to track to help you accomplish the goals that you set for yourself, right? We have an expectation of growth and learning. It's nothing crazy, but it's not that everybody is going to fit into this group because there is expectations about being committed to learning and to becoming better at what you do. So we're reinvesting pretty much every dollar back into Clearly Select. If it's something you're interested in, there's an application process. It's easy. It's nothing crazy. The link's right now in the chat, in the webinar chat. We'll also send it out via email afterwards for those who are interested. Or we'll send it to the whole group probably. But to have the meeting, you'll chat with Angela. Angela's amazing. She's our business development officer. She can see if this is the right fit for you. And if it is, my promise and guarantee is that I'm super committed to helping you grow your Invisalign practice and take control of your lifestyle to be able to do what you want to do. Like, again, for me, I work 1 week per month and I make as much money as I did when I was an associate working full time, right? Or not an associate, but when I was an owner doing all the general dentistry, right? There's ways that you can make this so extremely profitable and enjoyable, and you're giving back and doing really fun, interesting things where you use your brain. So honestly, guys, if you're not doing a high level of Invisalign right now, what are the chances you're going to do it later in your career? So why wait? Learn now and take advantage of more time that you can make more money and really feel passion over what you're doing.